Hi, everybody. My name is Jenny Flood. I am currently the APP chair of the symposium for the AHPBA, and we're glad to have you all here today. We're really lucky. At all of our meetings, we always talk about MRI being kind of like the redhead stepchild of radiology for all us APPs, and we're kind of like very not as familiar as we are with CT scans. So we're very fortunate today to have Dr. Gregory Grimaldi from Memorial Sloan Kettering, where I work. He's an associate attending radiologist at MSK, specializes in abdominal imaging, and his expertise is in using advanced imaging techniques like CT, MRI, X-rays to diagnose and evaluate GI and hepatobiliary cancers. He came to us from Northwell. We like to call that plucked him from Northwell. We're so happy and so fortunate that he's given us time to give us this webinar today. So I'll pass it over to him, and we are going to be able to take questions. If you have them, just put them in the chat.
Perfect. Thank you very much for the introduction. I'm happy to speak with you today at the end of a busy workday. But today I'm going to be talking to you about liver MRI. And in my experience with APPs, everyone is comfortable with CT and knowing the anatomy of CT. And MR poses a challenge because the pulse sequences can sometimes be very confusing, and the nomenclature can seem like Greek and be very disorienting to non-radiologists. So today we're going to talk about CT versus MRI for liver imaging. We're going to talk about the benefits of each modality. We're going to spend a fair amount of time talking about the basics of MRI pulse sequences and contrast agents. That might seem a little frightening, but I promise that I'm not going to talk about or focus on the physics. We're going to talk about the clinical utility of each of the pulse sequences. We're going to talk about clinical scenarios for liver MRI, which I'm sure you're very familiar with, and then we're going to go through a number of cases. Okay, so starting with CT, what you're familiar with, we have CT is based on atomic density. So we shoot X-ray beams through a patient, and things that are dense like bone or white, things that are not dense like fat or dark. We're familiar with looking at this. This is a cirrhotic patient. We have a dual phase arterial and portal venous phase CT, where we see an arterially enhancing lesion with washout, and we can diagnose hepatocellular cancer. But if we were just looking at a routine non-liver protocol MRI and we just see this blob on the CT, we can really only characterize its density and not much else. We would be suspicious for HCC, but we couldn't get very much more information out of that. MRI is going to be much better at giving us better soft tissue characterization. So what are the benefits of doing CT? Well, it's fast acquisition. We can do a CT acquisition in 1 to 2 minutes, maybe less. In general, when we do CT, we have a very large coverage. We often image from the thoracic inlet to the pubic symphysis. And we have excellent spatial resolution. If I reconstruct this arterial phase, I can show you the celiac axis and the SMA, a replaced right hepatic artery from the SMA. And if there was tumor involvement of these vessels, I would be able to tell you with high accuracy how that tumor interacted with the vessels because I have excellent spatial resolution. So CT is really good for divining vascular anatomy, assessing vascular involvement by tumor. We know this when we think about pancreatic cancer. But again, the limitation is that we only use density and enhancement pattern to characterize a lesion. So if CT is known for spatial resolution, MR is known for soft tissue characterization. So MR is based on proton spin and relaxivity. And you're really not going to get into any more of the physics other than making those two statements. But we get better soft tissue characterization because we have all these different pulse sequences that give us unique information. And as I said, we're going to spend some time going through each of those pulse sequences. But having such detailed anatomical and soft tissue characterization, we have better sensitivity for lesion detection with MR over CT. We have better evaluation of the biliary tree, as you will come to see. Here we can see a T2 bright signal within the biliary tree that's similar to fluid signal in the stomach and CSF. I can actually, with MR, quantify fat, iron, and fibrosis in the liver, whereas CT, I may only be able to say that there is steatosis in the liver. But with MRI, I can actually put an ROI on the liver and tell you exactly how much fat, what the proton density fat fraction is. And we can also get functional information from MR. We can assess cellularity with diffusion-weighted imaging, and we can assess hepatocyte function with hepatobiliary contrast agents such as EVIST. Problem for the non-radiologist, as you're well aware, is the MR pulse sequence word salad. So these are some names of pulse sequences that we routinely see at MRI. You may be familiar with T1, T2, diffusion-weighted imaging, but each vendor has a specific nomenclature for a particular type of sequence. It may be disco, it may be true FISP, it may be Fiesta, star vibe. Very confusing for the non-radiologist in knowing where to start. This is actually an MR of the liver from MSK. This is what I get as the radiologist on my console and what you will open up and see. And the problem is, where do you start? And so today I hope to be your cipher and to be able to decode this sequence of pulse sequences to give you an idea of where you can start and what you're looking at. So when I look at an MRI, it's sort of like solving a puzzle. So if I were to take this group of pulse sequences, I can basically break it down to 4 different types of sequences: T1, T2, diffusion, and post-contrast. And that's a little bit more simpler and easier to understand. So what do I look at with each of these sequences? What is the information I'm trying to get? Well, if I look at a T1 weighted image, as you'll soon see, that tells me something about fat and hemorrhage. So I can say if there's microscopic fat in the liver, if the liver is steatotic. I can tell you whether there's focal fat within a lesion, which might help me narrow my differential diagnosis. I can tell you whether there's hemorrhage within a lesion, which is clinically important and also can help me narrow down my diagnosis. I can look at T2 weighted images, which are fluid sensitive sequences, and tell you if something is cystic or not. I also know that different lesions have characteristic T2 signatures. So making an overall generalization, I can say that the brighter something is a T2 is less concerning. The less bright it is a T2, mild T2 signal and hyperintensity is usually a bad omen and usually seen with malignant lesions. Okay, moving on, diffusion-weighted imaging. Diffusion-weighted imaging is a very powerful sequence. It basically assesses water movement within a lesion. If you have restricted movement of water, that can tell you that the lesion is densely packed with cells or in a tense environment. And usually if we see a lesion that has restricted diffusion, the 2 things that I think about are tumors and abscesses. It's not 100% great, but it's very helpful. And again, helping us narrow our differential diagnosis. And then much like CT with post-contrast, some lesions have characteristic enhancement patterns, and we'll be able to go through some of those. So when I look at an MRI, it's not like CT where we just look at one image or maybe 1 or 2 phases. I'm looking at many different images to put the pieces of the puzzle together to try to figure out what's going on in the liver. So let's go through some of those pulse sequences. One of the sequences that you'll often hear us talk about is T1 in and out of phase. Here's an example through the liver of a T1 in phase and out of phase. Now I know this is out of phase because I have this etching artifact around the organs at fat-water interfaces. And without going into the physics behind it, I can tell you that there's a drop in signal within the liver from in phase to out of phase. The liver gets darker. And by noticing that the liver gets darker, I can say that the liver is steatotic. Now there's a sequence called fat ideal IQ. This is a GE term where you can actually put an ROI on the fatty liver. This tells me that the mean is 18, and I can tell you that the proton density fat fraction is 18, which is moderate to severe steatosis. So again, in and out of phase is helpful for us determining if the liver is steatotic. It's also helpful to tell me if a focal lesion is steatotic. So here I have in phase and out of phase. And we see a lesion that's barely perceptible on the in phase, but it homogeneously drops out on the out of phase, telling me as the radiologist that the lesion has microscopic fat. And that's very important because that helps me narrow my differential diagnosis. Lesions in the liver that have microscopic fat are either going to be a hepatic adenoma in the correct patient population, young females, birth control, or hepatocellular cancer in someone with a risk factors for HCC. So again, T1 in and out of phase is good for fat within the liver, fat within focal lesions. Now, another type of T1 weighted image we do is a T1 fat sat. So T1 pre, usually when we say pre is pre-contrast. And what we did in this sequence, as opposed to this MR before where the fat is bright, because typically fat is bright at MRI at T1, we can actually saturate out that fat. And we use fat saturated T1 when we do pre and post contrast imaging, because it helps bring out and make lesions that enhance stand out from the background. Now, at T1, when I see something that's bright, there's really only four things that it could be. It could be fat, which we saturated out. It could be protein, hemorrhage, or melanin. Presumably, the patient doesn't have melanoma, but melanoma mets can have T1 signal within them. Protein we usually don't see within liver lesions. And so here I have a liver lesion that has foci of T1 hyperintense signal. I can tell you that this is a hemorrhagic lesion. And again, when I think about hemorrhagic lesions in the liver, I think about adenomas and HCC. Let's move on and talk about T2 weighted imaging. So when we do T2 weighted imaging, we often do imaging in, well, one of my slides is a little messy, in the coronal plane and in the axial plane. And when we look at a T2 weighted image in the axial plane, things that are bright, like fluid in the stomach, fluid in the CSF, fluid in the bile ducts, help guide us. The T2 helps us guide us to fluid-containing structures. It can also help identify lymph nodes. In this case, I don't see any lymph nodes. One of my slides is a little bit out of sequence, so I can't show you, but we would be able to pick out lymph nodes within the sea of bright fat within this image. And then we can actually assess biliary anatomy. So I can look at a normal T2 and look at that bile duct, or I can weight the MR image very strongly towards fluid, and I can get an MRCP image. So basically what I did for this MRCP image is we took a radial array along this line. So it's sort of like we cut a line through the patient at the level of the bile duct. And I can actually play this, and you can see that there are multiple different cuts where we can take a radial array around that duct. And this helps us identify the biliary tract and biliary anatomy. So what do we have here? We have our pancreatic duct, our bile duct coming down. And it's actually very interesting here. If I change the duct, we can see how the pancreatic duct goes anterior to the common bile duct and doesn't join up in the ampulla. This is a case of incidental pancreatic divisum. Here's our bile duct coming here. Here's our cystic duct coming to the gallbladder, another fluid-containing structure, left and right intrahepatic bile ducts. Now, because we did a whole slab of heavily T2 weighted image, I'm also getting fluid in the left collecting system, fluid in the right collecting system, and fluid within small bowel. We have ways of eliminating those when we look at this, but you can see how you can use T2 weighted MRI to highlight fluid containing structures. And this is what we use when we do MRCP. Okay. Now we can also use T2 weighted imaging to assess liver lesions because some lesions have characteristic T2 signatures. Now, I'm showing you T1. These are 4 different livers with 4 different lesions, and we don't get any information about a lesion at T1 other than understanding that the lesion is in the liver. But if I look at T2 and I look at something like focal nodular hyperplasia, which by definition is normal liver with abnormal biliary radicals, we can see that the T2 signal of FNHs are very similar to the background liver, and you can barely perceive the lesion, except seeing its borders sort of deforming vessels. Whereas if we look at other lesions like HCC, we might see that the T2 signal is a little bit increased than background liver. If we were to look at a colorectal metastasis, that signal is even more increased. And if we were to look at something like a hemangioma, a benign lesion, they are generally homogeneously hyperintense, not quite the signal of fluid or a cyst, but very bright. So the T2 signal helps guide us into things that are ominous and things that are benign. So in general, things that are very bright are usually benign, and things that are mildly T2 hyperintense are usually malignant. And FNH is just a lesion that's a background, very similar to background liver, and can barely be perceived at T2 weighted imaging. Okay, so we talked about T1, we talked about T2. Now we'll talk about T1 post-contrast. Now this is where it gets confusing on my display on the left, because there are all these different terms for post-contrast. But usually we do a T1 pre-contrast, and we'll do delays at 60 seconds, 2 to 3 minutes. We'll sometimes do them even further on in the axial and coronal projection. Now at GE, they use the term disco for a high temporal resolution image. So its spatial resolution isn't great, but it has high temporal resolution. So in the first 2 or 3 of these disco sequences, it shows us early dynamic enhancement of the liver on the order of the first 5 to 10 seconds. So we can look here at this liver lesion in a disco image, and we can see early peripheral discontinuous nodular enhancement. 5 seconds later, we can start to see the background liver start to enhance, and even more of the background liver. And a delayed sequence, we can see that this liver lesion that had peripheral discontinuous nodular enhancement homogeneously enhances higher than the background liver at delay. This is the characteristic enhancement pattern of a hemangioma. Peripheral discontinuous nodular enhancement, which becomes greater than the background liver at delay. Let's look at this other lesion in a dynamic sequence. Very early, this lesion, as opposed to the hemangioma, is almost homogeneously hyperenhancing. That has a whole nother list of things that it could be in my background. We can see 5 seconds later, it's still homogeneously enhancing. 15 seconds, it's homogeneously enhancing. And we go to delay, and it almost blends with the background liver. This is the enhancement pattern of focal nodular hyperplasia. Sort of goes along with the biology of it. It's normal liver with abnormal biliary radicals. It's going to be very similar to the liver on some sequences. Moving on. Here's an early dynamic series, and you'd be hard pressed to actually see where the lesion is, but I'll highlight this region here. We can see 1, 2, 3 very early on. This is a hypovascular, so it's enhancing less than the background liver. If we go to delay at 2 minutes, it's a hypovascular. This is the appearance of a hypovascular metastasis, such as we might see from colorectal or pancreatic cancer. And yet another enhancement pattern. This is an early dynamic of a lesion in the posterior right hepatic lobe. At first, we have this rim of enhancement. Then we see the lesion is now hypervascular, so it enhances more than the background liver. And at delay, we can see it washes out with almost this capsular ring around it. This is the enhancement pattern of a hypervascular metastasis. This happens to be a neuroendocrine tumor metastasis. This could also be, if this is a cirrhotic, the enhancement pattern of hepatocellular cancer, which goes to the fact that we only use LIRADs when we try to diagnose HCC in patients who are at risk, because the enhancement pattern that you would see with HCC can be seen with hypervascular malignancies. So again, we're using the T2 signal to guide us as to what we think the lesion might be based on its T2 signal characteristics. We look at post-contrast, dynamic and delayed enhancement to try to figure out what the lesion might be. Okay, now we're moving on to functional imaging, diffusion-weighted imaging. On the left, we have a T2 weighted image, which again is a fluid-sensitive sequence. We can see the bright fluid in the gallbladder, bile duct, and CSF. And on the right, we have a diffusion-weighted image, which is very similar and comparable to a T2 weighted image. But we have different degrees of diffusion weighting. Without going into the physics, I'll tell you that higher levels of diffusion. If we see restriction, things would be bright, but not as bright as fluid. And these DW images are sensitive to water mobility in tissues. So tissues with dense cellularity, such as tumors or tense edema, abscess, will show high signal of diffusion. So as I mentioned earlier, this is a patient with cirrhosis. We have notching in the posterior right hepatic lobe. We have surface nodularity. And I mentioned that sometimes at T2, lesions may be barely perceptible or only mildly T2 hyperintense. And so here we can see a lesion in the liver, not so well seen. Maybe it's, we can see it, right? But I'd much rather be able to pick it out on the diffusion as a lesion than picking it out on the T2. So diffusion helps us to identify lesions or abnormalities in the liver, and then use the other pulse sequences to put it all together to try to solve that puzzle. So here we can see cirrhotic with a T2 mildly hyperintense liver lesion that has restricted diffusion. I'm going to be very concerned that that's a tumor. We're going to come back to this case because it's such a great illustrative case. Okay, one of the last components of the MR examination I want to talk to is contrast agents. So there are generally two types of contrast agents that we use. Most MRIs that we do, we use extracellular agents, and here are two of the most common ones we use in the United States, Dotarim and Gatavist. They have 99% renal excretion, so we're giving contrast much like we would use at CT, and we look for enhancement patterns of the liver and liver lesions. But with MR, we also have the ability to use a hepatobiliary contrast agent. The one we use the most in the US is Eavist, and this agent has 50% renal and 50% hepatic excretion. So what does that do for us? Well, if we carry out the study 10 or 20 minutes longer, we can get a hepatocyte phase. And at a hepatocyte phase, now the liver is going to take up the agent, it's going to process the agent, it's going to excrete the agent. So actually at 10 or 20 minutes, we see contrast in the biliary tree, which can help us to look for things like bile leaks in the postoperative setting, help us to look for biliary strictures or biliary anatomy if we're doing a liver donor study. But also, we should know that the liver and lesions with functioning hepatocytes will take up the agent, and lesions without functioning hepatocytes are going to be dark. So let's show some examples of how Eavist may help us. Well, it can help us increase conspicuity of lesions. And again, if I go back to a hepatocellular carcinoma, this is the same patient that I showed earlier that had that mildly T2 hyperintense lesion in the right hepatic lobe. We can see that the lesion is homogeneously hypervascular. At portal venous phase, it washes out, which is a characteristic of HCC. If you're wondering what the definition of washout is, it's a temporal reduction and enhancement in whole or part of a lesion compared to background liver. So we can see that this lesion enhances, and then over time at portal venous and delay, it becomes dark compared to the background liver. And this is the characteristic imaging appearance of HCC. But now we look at the hepatobiliary phase where the liver takes up all that agent at 20 minutes. We can see that that lesion doesn't have functioning hepatocytes, and so it's dark. So again, this helps us with conspicuity of lesions. It helps us for HCC. It really helps us for metastases. So if you're at a center that does a lot of colorectal cancer, we often do Eavist enhanced MRI for patients with colorectal tumors because that's one of the tumors that we can use surgery on and potentially cure patients if we eliminate all the metastatic disease, right? Most other tumors, pancreas, breast, if you have liver metastases, it's really not going down the route of surgery, but colorectal metastasis, there's potential. So here's a patient where at post-contrast imaging, I challenge you to find the lesion. The lesion's actually here in the left hepatic lobe lateral segment, not very well seen, but if we do hepatobiliary phase imaging and see the uptake, homogeneous uptake throughout the liver is now bright, the vessels are dark, we can see that that's the lesion, right? So it helps us with the conspicuity of lesions. Very important, because if this was the only lesion and the patient was having their primary resected, the surgeons might, at the initial staging, might cut out that left hepatic lobe or that lesion. Maybe they do a lateral segmentectomy. But I don't know if you notice, there's another lesion, very subtle, sitting around the periphery of the right hepatic lobe, which might change the surgical paradigm. But here we can see at EA Vista that it's dark. So again, we're using hepatobiliary phase MR in certain indications to help us with challenging HCCs, to help us with colorectal metastases, to help identify lesions within the liver. And then there's one other utility for hepatobiliary contrast agents such as EA Vista. They can help us, they're not perfect, but they can help us differentiate focal nodular hyperplasia from hepatocellular adenoma. So again, focal nodular hyperplasia, it's normal hepatocytes with abnormal biliary radicals. They tend to be very hypervascular. Sometimes they have a central scar, which does not enhance. At portal venous phase imaging, they sort of blend a little bit more with the background. And they tend to, because they have abnormal biliary radicals, they can't excrete the contrast agent efficiently. So with hepatobiliary phase MR, they generally have uptake that's brighter than the background liver. And so if we see a characteristic lesion that has this enhancement pattern and has hyper intensity to background liver at hepatobiliary phase, we're comfortable calling focal nodular hyperplasia. Now, a very similar appearance here in this hepatocellular adenoma, but this one, while it enhances similar to an FNH, becomes iso-intense to background liver, hepatocellular adenomas generally, again, I'm making generalizations, most hepatocellular adenomas don't have functioning hepatocytes and therefore can't process the agents. They're typically dark. So this is one of the sequences that we can use, or one of the, we can use this agent to help us with differentiating FNH versus adenoma. Now, some of you may be very savvy and have seen a lot of the times there actually are some adenomas that can take up the agent. And so we don't use and be bright at hepatocellular phase imaging. And so we don't use this exclusively. We use the hepatobiliary phase in conjunction with the other phases to help us differentiate FNHs versus adenomas. But to make generalizations, most hepatocellular adenomas are going to be dark at hepatocellular phase imaging with EA Vista. Okay, so that's really what I have for you on the T1, T2, and trying to be the cipher in decoding the list of sequences that we get at MRI. I can stop there and see if anyone has any questions that I can answer about T1 and T2 weighted imaging or the sequences that I've shown you. Okay. If not, we'll talk a little bit about the clinical scenarios for liver MRI. So you guys are ordering these, but I just wanted to give it my perspective. Often it falls into two categories. We're either trying to characterize a focal liver lesion. In the oncology world, I'm trying to tell you whether I think what I see in the liver is benign. Is it a cyst? Is it a hemangioma? And I showed you a nice classic enhancement pattern of a hemangioma. Is it FNH or adenoma? Are these benign things? Or are they malignant? And if it's malignant appearing, do I think it's something of hepatobiliary origin, such as HCC, cholangiocarcinoma, or gallbladder cancer? Often these go hand in hand. Or is it a metastasis? And then as the radiologist, I'm thinking if it's malignancy and it falls into the malignant category, is the disease confined to one lobe, right? Because that may change the surgical management or potential surgical management, right? I'm using diffusion. I'm using EA Vista and hepatobiliary phase to decide whether there are other lesions in the liver beside the one index lesion that we may have seen at CT that may change the patient's management. Maybe they go from surgery to local regional therapy, or they go from surgery to radiation therapy. How many lesions, right? 1 to 2 is different than 5, 6, or 10. So again, we're trying to identify where the lesions are in the liver, how many lesions they are, because that may change the management of the patients. Then I'm using things like T2 and diffusion to help me see if there's any suspicious lymphadenopathy. And when I think about lymphadenopathy, I'm also thinking, is it regional adenopathy? Is a patient with a cholangiocarcinoma, do I see abnormal nodes in the porta hepatis? Or am I seeing nodes in the para-aortic region, which may put me in the metastatic category? So again, I'm using all of those different sequences, T2, diffusion, to help identify lymph nodes, where they are, and how they might relate to the tumor. And then, is there vascular involvement? Again, CT is better, but with MR, we can call vascular involvement, particularly in the setting of HCC, where you can get invasion of the portal veins and hepatic veins. Okay, so putting all the pieces together, T1, T2, diffusion and post-contrast, that's what radiologists do when we look at these images to try to come up with a solution to the clinical problem. So I have about 5 or 6 cases here that we're going to go through. I'm just going to take them like I'm a radiology resident sitting in the reading room. So hopefully you'll get the experience. So these are 4 images through the liver. And in the right lobe at T1, I see a well-defined lesion in the right hepatic lobe. At T2, it's markedly T2 hyperintense and homogeneous. Homogeneity is important for this diagnosis. It's not quite as bright as the fluid in CSF, so I don't think this is a cyst. It's not a cyst because I see enhancement at post-contrast early and late. And the enhancement pattern that I see is sort of a peripheral discontinuous nodular that puddles at delay. And so this is the classic appearance of a hemangioma. And moving on, we have 5 MR sequences. We have a T1, a T2, early arterial, portal venous, and hepatobiliary phase. At T1, I can barely perceive if there's an abnormality in the liver, but I'll put your eyes to this. There's a lesion that's very similar to background liver. T2, again, very similar to background liver, maybe a T2 bright central scar. And I guess I can give one other teaching point that I give the residents and fellows I work with. If you see a lesion that's very similar to background liver at T1 and T2, you should really lump and chunk and think about things of hepatocellular origin like FNH, adenoma, HCC. And so we look at its enhancement pattern. This lesion homogeneously enhances, homogeneously hypervascular. At portal venous phase, it blends with the background liver. So now I'm thinking FNH versus adenoma, and we do hepatobiliary phase imaging. The liver is really bright because it's retaining and processing that agent. And we see that lesion has homogeneous uptake except for the scar, which is dense fibrotic tissue that doesn't have functioning hepatocytes. So this is a classic focal nodular hyperplasia. Okay, case number 3. We have a T2, a diffusion weighted image, early and late post contrast. And here at T2, we can see normal morphology liver. We see 1, 2 discrete lesions within the liver that have mild T2 hyperintensity. And again, mild T2 hyperintensity is a worrisome feature for me. We see restricted diffusion. Now I'm thinking malignancy, right? Patient doesn't look like fluid, doesn't look like a cyst or an abscess. Restricted diffusion, maybe there's a 3rd, maybe there's a 4th, maybe there's a 5th lesion. So this is the benefit of diffusion weighted imaging. Here we see early rim enhancement. Rim enhancement is very characteristic of a metastasis. It's also characteristic in early phases of a cholangiocarcinoma. So we see early enhancement, targetoid sign, rim enhancement. This would fill in at delay a little bit. This is the characteristic of a hypovascular colorectal metastasis. Again, if I were to do EOVIST, I'm pretty certain that some of these little dots that we see at diffusion are going to be dark at hepatobiliary phase, probably also small metastases. That's the benefit of doing EOVIST. But even alone, if I had, say, a patient with pancreatic cancer and we were staging them, and I didn't see anything in the liver that I could prove was a cyst or hemangioma, but I saw a few small, tiny dots within the liver at diffusion, I would be very concerned that the patient had early hepatic metastatic disease. That is how powerful this diffusion weighted imaging can be. Okay, and here's back my classic case. I love this case so much because it's just got all the classic features. Cirrhotic, there's our lesion within the liver at T1, mild T2 hyperintensity, restricted diffusion, arterial enhancement, washout at early and later portal venous phase. And there's our hepatobiliary phase that shows this lesion as hypointense, no functioning hepatocytes. This is the imaging appearance of HCC. Okay. Our last case, This is a patient with cirrhosis. Doesn't really look super nodular, but there's an expanded gallbladder fossa, and I can tell you this patient was cirrhotic. We see a lesion in the right hepatic lobe at T1. At T2, it has mild to moderate T2 signal hyperintensity. At diffusion, it has restricted diffusion. So again, I'm concerned, right? Any lesion in a cirrhotic is going to be concerning. Patients are at risk for two different types of tumors, right? They're at risk for HCC and they're at risk for cholangiocarcinoma. As opposed to the HCC, which had non-rim arterial phase enhancement, this lesion has rim arterial phase enhancement. Much like that metastasis that I showed you, it has early rim enhancement. And if we look at the center of the lesion where HCC washes out, this lesion actually gets more hyperintense at delayed phase imaging within the center. It almost looks like a target where the center is brightly enhancing and the periphery is a little bit washing out. This is the characteristic imaging appearance of cholangiocarcinoma. They tend to have a little bit more T2 signal than HCCs. They tend to have marked restricted diffusion. They tend to have peripheral early rim enhancement, and they tend to fill in, but not homogeneous and hyperintense to the background like a hemangioma, but just tend to fill in because they have fibrotic tissue within, and fibrotic tissue enhances in a delayed fashion. And of course, it's really important, especially if you're at a transplant center, to differentiate between HCC and cholangiocarcinoma in patients who are at risk because they're managed completely differently, right? HCCs can often, if they're within criteria, can go to transplant. Most centers across the country, there are some exceptions, are not transplanting cholangiocarcinomas unless patients have gone through a pretty extensive management program. I'll leave it at that. So this is cholangiocarcinoma. So I'm done for the day of walking you through MRI for the non-radiologist of the liver. I want you to walk away with some key notes. MRI is a problem solver, right? CT is still our workhorse, of course. Each pulse sequence that we do, T1, T2, diffusion, post-contrast, it's one part of the puzzle. We need to put all of those puzzle pieces together in order to come up with a diagnosis. I want you to remember that MR has excellent sensitivity for focal lesions, particularly EVIST, hepatobiliary phase, and diffusion-weighted imaging. It has excellent soft tissue characterization. We can tell whether there's fat, fluid, soft tissue within the lesion. And then if there's one thing I want to leave you with as a last moment is T2 non-fat sat, this image that I showed you on the left, and the 60-second post-contrast are probably the most similar to CT. And so if you had to open up an MRI and just get one or two images that you looked at to try to get a lay of the land, these are probably the two best sequences for you to look at. I'm also going to leave this slide up. This is resources. They're basic articles on liver MRI that we use to train our first and second year residents. I think if there's anything in this talk that sort of rang a bell for you, or you wanted to go back and refresh yourself on the pulse sequences and what their utility is, this is a great article that does not really touch on the physics, but really just goes to the clinical utility of each of the pulse sequences that we discussed today. So thank you for your time.
This is great. I have one question. I find like I only really order EVIST if I'm working up FNH versus adenoma. So I'm wondering when should we put that as the contrast that should be used? Because doesn't it defaults, at least at our institution, to gadolinium mostly, right?
Yeah, so what I like to do, it's a little bit different at each institution. I'll tell you what we did at my former institution. Sometimes it can be really hard with small hemangiomas to identify, because hemangiomas are not lesions that are of liver and therefore won't take up the agent. So I always like, as a general rule, having one MRI that's done with an extracellular agent to define the lay of the land, characterize our hemangiomas in the liver, and then if patients are going to plan surgical resection, to move on to EVIST to give the lay of the land. It also differs whether the center has a hepatic artery pump program or not, right? So programs that have hepatic artery pumps, it's not so important, at least in the early stages, to pluck out all the tumors if they're going to get a pump. Whereas at other centers, it may be more important upfront to understand how many tumors there are and potentially manage them surgically upfront. So I think that's a good algorithm, and one that most institutions use is to do an extracellular agent first to diagnose, and then pre-surgery to do an EOVIST enhanced MRI.
Thank you. That's very helpful. I
Well,
think
what
there's a
is
couple in the chat too.
okay? If I can open this up. What do you say to skeptics who feel this is time and money without real clinical benefit? Are you talking about MRI in general for clinical benefit, or MRI of the liver versus CT? I'm not sure how to answer that. Maybe we'll skip that one. One question, we see a lot of patients for restaging who are post-liver directed therapy with Y90. Can you comment on how to best assess post-treatment response versus an active lesion on MRI? Okay, so Y90 is actually very challenging. So we use Y90 for patients with HCC. We use Y90 for patients who have metastatic disease. When you use Y90 as opposed to the other methods, so let's start with the different methods that we can use for treating liver disease. If you have a lesion and you do things like a bland embolization or an ablation, anything that enhances within the treatment zone is going to be viable tumor when you do an MRI or a CT after doing those therapies, ablative therapies, or just bland embolization. If you use radioembolization, lesions can still enhance after you do the radiation or radioembolization. And so what you're looking at is to make sure that things that enhance decrease in enhancement over time, and there's no new enhancement, or there's no new restricted diffusion or new T2 signal. So I'll use HCC as the poster child. Again, if we use radioembolization or radiation therapy and we look at them with MRI afterwards, MRI is a little bit better than CT because in addition to the post contrast, we have the T2 and the diffusion. And so if you have new diffusion within a lesion or new T2 signal at the treatment site, those are going to be areas of concern. And that's why MR has slightly better efficacy after those treatments than CT. And then you can also, look for lesions outside of the treatment zone. Okay, EOVIST versus Scatavist. Yeah, so again, it depends on what your clinical scenario was. I think that goes back to the last question I was trying to decipher. So I think EOVIST gives us information FNH versus adenoma definitively and helps us manage those patients. And I think if you need to know exactly how many lesions are in the liver and where those lesions are, because it might change your surgical algorithm, EOVIST is very helpful. And using those extra 10 minutes in that hepatobiliary phase contrast can really get you information. Okay, what is the best sequence to evaluate perihilar cholangiocarcinoma? Well, I think if you're looking at the vasculature, CT trumps MRI because it has the spatial resolution. We can look and see what the vascular anatomy is, and if there are variants, if there's soft tissue surrounding the celiac axis, the hepatic arteries, if there's soft tissue, the perihilar lesion, if it's deforming or abutting the portal veins. So CT is great for the vascular components. MR is really good. We look just at that radial MRCP and we see where the level of biliary obstruction is. Do we think it's hilar? Do we think there's obstruction that's going into first or second order radicals? So we use the MRCP to try to define the level of the tumor. We use diffusion weighted imaging to look outside of the hilum, to look within the liver parenchyma to see if there's any metastatic disease within the liver parenchyma itself. And we use post-contrast as well to help define the tumor. Cholangiocarcinomas are fibrotic tumors. They tend to enhance in a delayed fashion. So again, we use all different sequences, but I would say the fluid sensitive sequences in MRP to define the level of the tumor, post contrast to define the extent of the tumor, and diffusion to look for disease elsewhere in the liver. Okay. Any other questions?
Yeah, I had a question. Thank you so much for this talk. It's been very enlightening. I'm one of the fellows in HPB, so in starting my career out, when we're finding incidentalomas on CT with IV contrast for an ER patient, I know a lot of people debate on whether we should go to a CT with hepatic protocol or an MRI. As far as defining the lesion, do you feel strongly on which one we should go to? I know on the surgical side, it's easier for us to read CTs because we're more familiar with it and it helps with the vasculature, but overall, just in the diagnostic.
Yeah, when you have an indeterminate hepatic lesion at CT, it's probably best to go to MRI because of the soft tissue characterization, the ability to characterize the soft tissue is far superior to MRI. I think you'll get much more information out of the MRI. So usually that's the algorithm, is to go to MRI.
Perfect. Thank you so much.
You're welcome. Okay, anything else?
Yes, this is Heather from UPMC. I had a question. Did I hear you say that you recommend EOVIST for looking for biliary strictures, like in HAI pump patients? Is that better than gadolinium for the MRCP?
No, we typically just use routine MRCP to look for strictures. EOVIST is used in some instances to help look for bioleaks and the level, the anatomic detail and level of a bioleak. So if you have a postoperative patient where you suspect a bioleak, you can do a nuclear medicine study to define that leak. A regular MRI with normal extracellular contrast agent can help you identify collections. But if you actually wait up to an hour, and if we have a high suspicion for a leak, we usually take the patient off the table, do another patient, put them back on at 1 hour, and you can actually define whether there's contrast that's leaking out of the biliary tree, and you can often define what the level of the injury is. So it's more helpful for bioleak, but not necessarily for stricture in patients with with a stricture from a hepatic artery clot.
Okay, thank you so much. This was great. Thank you.
Yeah.
Any other questions? Well, this was really, really informative. Thank you so much, Dr. Grimaldi. I mean, I think this just answered so many questions and you broke it down so nicely that everybody could follow. So we really appreciate it.
Perfect. I'm happy to do this. And if anyone has questions, maybe you can just put in my contact information, and people can feel free to reach out to me with any particular questions they may have.
Great. Thank you.
Thank you
Alright.
for your
All right,
time.
everybody, have a good evening. Barbara, thank you for setting this up. And thanks to the AHPBA for, again, supporting all the APPs. And just a, shameless plug to get your abstracts in, and please come to the meeting. Tell your friends, if you're a fellow or an attending on the call, bring your APPs. It's a great meeting and it's really well attended, and it's so well supported by the AHPBA. So we're really appreciative for this opportunity. Thank you, Barbara.
Thank you. Good night, everyone.